Yes.
Nice to meet you guys.
Hello.
Mustafa,
Hello.
good to see you again.
Hey, Ivan.
So, Iggy, I'm going to put my introduction slide then, or you're going to put the music?
Nice to meet you. I'm gonna put the music. We are live in YouTube. Let me share the. You want to share your screen real quick, Dr. Marcos, to make sure we're
No,
good?
it's okay.
It's okay,
I'm,
right?
yeah, I'm good.
Let me go ahead and share this, and we'll start shortly.
Martin, mute your microphone.
Oh yeah.
We
Thank
don't
you.
hear your.
All right, we're going live in 5, 4, 3, 2, 1. Our webinar has started.
Evening, everybody. Thanks for joining us for our usual monthly Cerebrovascular Skull Base University of Miami Symposium. This is the 48th one today on October 13. And I'll introduce our wonderful speakers in a few minutes. But first, let me recognize my co-directors, Carolina Benjamin, Mike Ivan, who's with us today, Bobby Stark, and our monthly panelist, our Infolded Fellow, Eva Wu, and our post-residency fellow, Matthew Sun. Matthew came to us from UCLA and is going to have a case to discuss with our panelist, and so is Eva as well. She will show a case, and of course, we'll discuss your questions. Many thanks to the team that makes these webinars now going since COVID times, really, and I'm delighted to see many of you returning to watch us. And these are the links. If you are interested in viewing the recorded ones, they're all on our YouTube channel. You can also watch the webinars that my partner, Mike Ivan, has on brain tumors, also a wonderful series of webinars that we can spend hours watching. So for tonight, great pleasure to discuss, I would say, a partially controversial topic, which is the management of acoustic neuromas. Our first speaker, unfortunately, is not with us, but he just sent me an hour ago his pre-recorded presentation. He is stuck in an airport and is flying, and he's sorry he cannot be here, but he will be here virtually. And this is Dr. Ashok Astagiri, who's professor of neurosurgery, director of surgical neuro-oncology and skull base at UVA in Charlottesville. Following that 20-minute presentation, I am delighted to have my very good friend and coming to us from the Czech Republic live. It's late for him, and I really appreciate Martin Sames, who is professor and chair of neurosurgery at University J.E. Purkyně in Masaryk Hospital in the Czech Republic. And Martin is going to, Martin, of course, does cerebrovascular and skull base. Tonight he's going to talk to us about planned subtotal resection and gamma knife radiosurgery and what their experience has been with the long-term results. And last but not least, Mustafa Bashkaya, who I'm sure all of you know, because he has a phenomenal following on Twitter with all his educational series he does. But Mustafa is professor of neurosurgery, director of skull base surgery, neuroanatomical lab, microsurgical skills lab, cerebrovascular fellowship, and of course in Madison, Wisconsin. Mustafa, true to himself, will be very aggressive in his talk, and he's going to talk about aggressive microsurgery, refining the technique, and learning from mistakes. So without further ado, I'm going to stop sharing, and I'm going to play the pre-recorded presentation. Does it play well? Let's see.
Shock and the remainder of the organizers of this International Webinar Symposium. Thank you for the opportunity to be able to join this esteemed panel in discussing
We can't hear it, doctor.
and then I'd like to really focus mostly on
you can hear him
types
now?
of patient factors.
Yeah, now we can. Now we can.
Characteristics impact decisions about how to manage patients. And then I have a longstanding history and interest in patients with NF2. So I'd like to present a couple of slides specifically pertinent to that population, which we know are some of the most difficult patients to manage with acoustic neuromas. Before I start, I want to say that the CNS did put together a wonderful set of review of literature and guidelines that are readily available and free to access. You can download the CNS Plus app. Registration on that website is free. You can download it and have access to some of the common questions and literature-based answers on what would be supported with regards to standards of care. So, obviously, before we start, I think that there are three main options for management of acoustic neuromas, right? We often think about surgery. That's probably most of the discussion that we're going to have today. But of course, gamma knife is a form of surgery, and radiosurgery we're going to care about as a tool, either as an independent or a surgical adjunct to management of these types of tumors. And then the third option, a lot of people refer to it as watchful waiting. I like to refer to it as deferred risk because oftentimes when we're watchful waiting, what we're thinking about is not really having an increased risk associated with deferring surgery. And there are many situations in which deferred risk is appropriate. And I think that, we'll get into a little bit of that. First thing I have to say is that I think the most important aspect of management and decision-making with regards to acoustic neuromas is setting clear expectations and goals with patients, and also trying to do that for yourself so that there's a standardized approach that you cultivate and utilize in order to approach these tumors. And so, what kind of things normally do we think about that help us determine how to best manage the patient? Well, obviously, I think a lot of this information is gained by a detailed history and physical examination, audiogram, and then obviously the imaging provides a lot of additional information. When we think about the history and physical exam, obviously, I think one of the key factors in determining surgical versus non-surgical management or radiosurgical management is the presence of signs or symptoms. And then we think about how do we manage these tumors a little bit differently and have two or multiple neoplasia syndromes. Of course, age is a huge factor, not only in the sense of overall health status and comorbidities, but we also know that the natural history seems to change a little bit for patients who are older and have small tumors. Certainly, hearing status and findings on an audiogram are going to impact us greatly as we try to decide which strategy is best. And of course, important findings on imaging not only can help us decide what to do, but also going back to setting goals and expectations can help us understand a little bit about what prognosis may be in certain situations with respect to hearing and facial nerve preservation. So let's talk a little bit, about obviously the audiogram. I think there's sort of a line in the sand that many of us use for determination of serviceable hearing. And that's the 50-50 rule, 50 decibels on pure tone audiometry, and then 50% speech discrimination score, and how serviceable and how much can we go to try to preserve that. I think that certainly impacts our surgical approach and deciding whether to utilize radiosurgery or not, and whether to utilize observation. And when we get to what kind of imaging findings can impact things. We're going to talk a little bit about obviously size, location, presence of a fundal cap of spinal fluid, and whether there are cystic changes in position of the jugular bone relative to the tumor. But there are also many other findings on CT scans and MRIs that can help us, just make surgery go more smoothly, trying to understand where emissary veins are, whether you have to really be worried about a spinal fluid leak or not. You can see here the mastoid air cells don't even extend into our retrosigmoid approach on this case. We have patients with, multiple tumors and we'll talk a little bit later about this, is how do we approach that situation? How does that alter our surgery and our tactics with regards to treatment? And then obviously, high resolution T2 imaging, I think, has really revolutionized our ability to see nerves, whether they be lower cranial nerves or how tumors impact the fifth nerve, but also visualize peritumoral cysts and intratumoral cysts as well. Instead of sort of just going through a rigorous, flow chart in which we try to generate a systematic approach to treatment of these tumors, I'm going to try to go through it in a case-based way, which I think might be a little bit more fun, and talk a lot, provide a few little nuggets of information that may help you understand why I chose certain management paradigms in certain situations. So the first case is a 50-year-old gentleman with right-sided hearing loss, and he has mild hearing loss. Mild dizziness. As you can see here, he has a speech discrimination score still 72%. The speech recognition threshold is 20 decibels, and you can see that he's just around the 50 decibels here. And so he has serviceable hearing. And his MRI shows this tumor, small to medium size, presumed vestibular schwannoma. And the question is, how do we approach that? I think obviously one of the things to consider, of course, is radiosurgery. Radiosurgery, since the seminal publication by Doug Concioca, Dave Lunsford, and Flickinger in the early 90s with regards to long-term outcomes, definitely showed that radiosurgery for these tumors, was accompanied by extended local control of tumor, as well as hearing preservation. And so I think that certainly that's one consideration. A follow-up to this was a more recent article published in JNS that's showing that hearing preservation can be for extended periods of time with using radiosurgery, especially for Gordon Robertson 1 class hearing status preoperatively. So while that's the case, I think, we have to think that there is some risk associated with even utilization of gamma knife radiosurgery for treatment of these tumors. And so I would be a strong advocate for patients with marginal to no symptoms to utilize observation first. And so the reason I say this is there have been numerous studies that have shown that, especially in patients who are elderly, that there is a significant proportion of tumors that will not progress. And so the question becomes, is some treatment even necessary at all? When we think about goal setting, expectations, and weighing whether we're actually providing a treatment that's helpful with regards to radiosurgery, there's certainly a risk associated with it. And I think that if we are treating a significant number of patients or tumors that really will show no progression, then the question becomes, how are we benefiting these patients in any way? The second aspect of that is, I think that patients will have a be significantly more amenable and accepting of risks associated with surgery or gamma knife if you show that their tumor is growing first. When the growth of the tumor occurs, patients understand the necessity for treatment. And so I always recommend repeat imaging in 6 months as initial management for smaller to medium-sized tumors with no urgency for treatment. So in this situation, this is the patient here, and then this is his follow-up several years later. Now, he's this young man who's in his 50s, going to have a lifetime of no surgery and no risk. Maybe not, right? But I think that there are a number of patients who may have extended periods of time without requirement for surgery. And even if you get 5 or 10 years without having surgery, the necessity of have radiosurgery or surgery, the concept of deferred risk certainly makes it worthwhile that patients have had that period of time without taking risk and having the treatment. Second case I wanted to go through is a 49-year-old woman who presented with right-sided tinnitus, hearing loss, and 3 months of right facial pain and a sense of imbalance. You can see very similar to the last case, has excellent hearing on the right side. I'm meaning that she has a speech discrimination of 96%. And through the mid frequencies, she still has preservation of good hearing function. When we take a look at the imaging, we can see that this is again another small to medium-sized tumor. And we look at the T2, and you can see very clearly, especially near the top, that there is impaction of the 5th nerve, presumably at the rodentary zone, causing her trigeminal neuralgia. And you can also see on the T2 sequence, you can see some edema inside the middle cerebellar peduncle, and then you see a small cyst posteriorly as well. I think everybody should understand that when we talk about initial observation, we're really talking about asymptomatic tumors. For this patient, obviously retrosigmoid approach, since a significant portion of the tumor is in the posterior fossa, was the approach that I utilized. I oftentimes tell patients it's about a 25 to 50% chance for hearing loss associated with surgery, and that really manages expectations. But patients should, with this size of tumor, expect to have good facial nerve outcomes. And as long as we set those expectations, then we can move forward with surgery. The next case I have is a 52-year-old female with left-sided hearing loss, blurred vision, and imbalance. I don't think for most of us the question here is whether we need to have an observation period or whether we use gamma knife. It's rather, what surgery is best and which approach is best. And I think that, there are a number of factors that we typically look at to try to understand which surgical approach might be best. Of course, the 2 types of hearing preservation surgeries are retrosigmoid and middle fossa approach, and translab approaches may be limited by high writing jugular bulbs and require fat grafts. I think that there are a number of factors that you can look at to try to help you pick which surgical approach you're going to use in this patient. I put this case in specifically because of the position of the jugular bulb. There are many cases in which the jugular bulb is even much more high riding and really limits not only your view of the lower portion of the tumor, but maybe even of the waist of the tumor itself. And so that distance between the middle craniofacial floor, the 10th foramen, and the jugular bulb is a key element to look at when you're trying to determine whether you can reach the bottom portion of the tumor. Certainly, so position of jugular bulb is an important one. Next, with regards to hearing status, we discussed, position of the tumor for me makes a big difference. When I see a majority of the tumor in the posterior fossa, I lean towards doing the retrosigmoid approach. We do both approaches consistently, both translab and retrosig, but I think that certainly one of the most important considerations is familiarity and ability. You can have the most important thing for many of these surgeries, especially, for example, for hearing outcome. I think the chance of hearing preservation, regardless of the approach you choose for this surgery, is very low. So a translab approach is certainly is extremely appropriate as long as you can manage the jugular bulb appropriately. And so there are, things about expectation setting. When we talk about how far out into the internal auditory canal is the tumor, I know that there are correlations with immediate facial nerve outcomes, so you can counsel patients appropriately with regards to that. And then also the chances of hearing preservation drop as the tumor extends bilaterally into the internal auditory canal. 2 points that you can help set expectations with the patients. And as I said, translab approaches for this type of tumor, it's not rolled out. There've been, I think virtually every operation, the majority of operations done at the Hauser Institute are done with the translab approach with better than excellent outcomes. And it's through strategies of managing high riding jugular bulbs and managing expectations that enable them to be extremely successful with utilizing translab approaches, even for extremely large tumors. And so with that, I think that it's sort of half and half which approach you utilize. I tend to use, for a case such as that one, high riding jugular bulb, large tumor, majority in the posterior fossa, I would like to use a retrosigmoid approach. Next case I have is a 65-year-old gentleman with tinnitus, hearing loss, and imbalance. And when we take a look at this, present you with the imaging here, you see a left-sided vestibular schwannoma with a rather large cyst associated with it. I think traditionally surgery for tumors with large cysts has been the standard of care, and this is primarily because they are often space-occupying, symptomatic, and the cyst can be associated with that growth. Certainly something we should tell patients when they lean towards wanting to do observation period. On the other hand, we know that they are associated with lower rates of complete resection, and facial nerve outcomes may be inferior, at least in the immediate postoperative period, compared to similar non-cystic schwannomas. In this case, I did a retrosigmoid approach, and we achieved a complete tumor resection. Patient is doing well with excellent facial nerve outcomes. It does not have usable hearing. But, I wouldn't put this case up if it was just very straightforward, especially with more recent publications. So despite, sort of the frequent admonition that most patients with cystic changes should have surgery, I think that more recent literature has really raised questions about initial management for patients who are asymptomatic with moderate size cysts. Can radius surgery be used in those circumstances? And certainly there are compelling publications that suggest that that's very possible. And I think you just have to use the presence of symptoms as an important bellwether and determinant of what surgical or management approach you want to try to utilize. Last case I have, hopefully I have a couple minutes here to talk about this one, is the 13-year-old gentleman with headaches, facial weakness, and hearing loss, and profound ataxia. His cranial imaging showed this massive acoustic neuroma. And then when we take a look and put that in perspective with what else we see. We see this holocortical adenoma, multiple schwannomas and ventral to the spinal cord. What do we do with a patient like this? Obviously, this patient has NF2, and that plays in itself as a critical role in how we want to try to manage his disease. We know that NF2 itself portends for worse treatment outcomes. Whereas we have 96% or above local control with radiosurgery, we know that these radiosurgery success rates are much lower in patients with NF2 along with watch. The recurrence rates are 60% even for small tumors with complete resection because we can't defeat the biology of disease simply with a knife. And so I want to talk a little bit about natural history and how these tumors are very different than our sporadic tumors. Obviously, I had the opportunity to monitor patients at a very young age. And we noticed that there were patients, oftentimes, most patients with NF2 will have multiple tumors in the internal auditory canal that are coalescing and essentially giving rise to this multilobulated appearance. We went on to remove these multilobulated tumors piecemeal, showing that they're actually polyclonal derivation and multiple tumors present. And so by doing that, I think we better understand the natural history and also the treatment failures that occur with radiosurgery when we're trying to treat 5 or more tumors at the same time. Of course, the probability of success is going to be 0.95 to the X, really sort of mimicking what we see in practice. And so there's still, I think, a role for gamma knife radiosurgery, even in the treatment of patients with NF2, especially with the rightward shift, some of this, because sometimes all we're trying to do is get procrastination. We know we're not curing the disease, and we know that medical therapeutics are hopefully advancing. Now, there's something about NF2 also that's very important, is we need to be very critical about the question and the surgery that we're trying to accomplish, because we know we're not curing disease with surgery. For example, in this situation,
how do I go back
this patient had progressive hearing loss in her left ear, remaining here. And I elected to resect the small meningioma that you can see here on the left side and just decompress and do a bony decompression of the internal auditory canal. And you can see that she had significant improvement in her ear, in her hearing.
Dr. Marco, please unmute.
Hearing management in these patients, which is very critical to their quality of life. Of course, we also have medical treatments that have been indicated in patients with NF2, with both tumor control and 50% of patients with hearing improvement, which only increases the armamentarium of opportunities for intervention and makes it even more difficult for us to manage these patients. I think the key thing with NF2 is that we need to be thoughtful and considerate about the different approaches that we can use, and that their natural history is significantly different from the general population. And please, although it's not our general approach in skull-based surgery, when there is neopure, procrastination can be good enough in cases. In this situation, what did I do? I did the Retrosigmoid approach, extended it down, and did multi-level hemilaminectomies, and removed the majority of the internal posterior possible bone into the tumor, and then went down into the cervical spinal canal and removed all the ventral portion of tumor as well. And so, in summary, what I can say is, as far as determinants of best management, I think the goal should be to be thoughtful, set goals and expectations, and try to stay up on surgical, radiosurgical, and medical advances that seem to be on a daily basis and can significantly modify how we approach and manage patients with acoustic neuralgia. Thank you for your attention.
I think that was great. Sorry, Ashok cannot be with us to answer questions. So we're going to move on to Martin. Martin, if you could share your screen and unmute yourself, and hopefully it will work. Perfect. And just unmute yourself.
Perfect. Okay. Can you see my screen? Okay.
Absolutely.
Absolutely. So my title, it's a bit provocative about long-term results after partial dissection and gamma knife, but I will criticize this approach because we have no long-term results about this policy. So if we criticize this approach, so I should show you how is our results and show the long-term results of the gamma knife. But let's move. It's not moving. So maybe here.
Click on the screen. Click on the presentation. You will move.
Yes.
There you go.
Okay, so we first I show our philosophy, our operations philosophy, and our results, and then we will see that we have no results after gamma knife. So our philosophy is the large vestibular schwannoma we do only by retrosigmoid approach in the syncing position. It's influence of the Majid Sami. Germany is very close to us, and in the technique, just very shortly, we preserve the lower cranial nerves. Then we stimulate dorsal part of the tumor. If there is no dorsal position, we do debulking. Then identify facial nerve from the brainstem, and then we drill the canal and meatus. It's very important. We will see that some departments doesn't do this, and then we go from both sides of the facial nerve and we remove the tumor by technique of the SAMI. It's a blunt technique, or sometimes sharp if the blunt technique or elevation of the tumor, it's not possible. And very important is a minimal stimulation threshold. If we have 0.05, so we can do radical resection. If we go higher and we have 0.3, so then we leave some film of the tumor, but leave the as thin of the film as possible. It's best for the long-term prognosis. So just 3 examples. This is a large vestibular schwannoma with very long meatus, very long canal and tumor here. So this is very, very demanding, but we should drill it. You can see they're removing the end of the tumor in toto. It's not always possible. Radical resection. Next case, cystic. We knew that adherence, it's more here in cystic tumors, and we have only linear enhancement. So it means near total resection with very good long-term prognosis. And very huge tumor, but here is very favorable distal from the CSF gap, which is good for technique and also radical resection. So this is our philosophy, and of course the preserved facial nerve is the priority. So the first conclusion is very important, is the minimal stimulation threshold, and if it is higher than 0.2, so then we leave the film on the nerve. This is a very important article. It's very strict, and we can see that after gross radical resection, we have recurrence about 3.8 after 5 years. But if we do only subtotal resection, it means between 90 and 95 volume of the tumor, and so there is a 27 recurrence rate, which is very high. And we have same philosophy with the Professor Mastronardi in Roma. So we did our cooperative study. It's only a retrosig approach. This is years. We have 57 patients, and we had 30% of the cystic tumor. Here's age, and we did 72% total or near total resection. And in this philosophy, we have 84% of the high Haus-Brackmann 1 and 2. So if we see in the literature, in the radicality, we are in the middle comparing the other departments, but in the results, I think we have a very good results, 84. It's very good results for the Haus-Brackmann 1, 2. We had a good luck because dorsal position was very low of the facial nerve, no big complications, no mortality, and very important slide, we had 5% recurrence after 5 years, which is very important for comparing with the gamma knife philosophy. So if we conclude, so we have these results, and we have regrowth only 5%. And for the patients, the regrowth, it's not nothing bad because it's only a radiological diagnosis. We see there is 1 millimeter more, so we indicate radiosurgery, and for the patients, it's no complications. It's a very smooth course of this philosophy. And now, if we compare with the different philosophy, which is a planned partial surgery, it's followed by radiosurgery. So we criticize this approach. This approach has appeared in 2003, but we have no long-term follow-up published in this philosophy. So we have only 5 years follow-up. Also, we mentioned already today the CNS recommendation. There is no evidence to support subtotal resection followed by radiosurgery. It's a very important recommendation. And also the literature, it's very sparse. So we have from Japan, EVA, they reported recurrence at the 14%, comparing with the radical surgery. It's very high after 5 years. Then we have group in Netherlands. So they published if the patient is younger than 50 years old, the tumor regrowth is 37%. And if the residual volume is greater than 6 cubic centimeters, also regrow around 40%. So it's very, very high for the patients. And the third group from Lausanne, from Switzerland, they published a paper. They resect only 69% of the volume. I think it's very low. They don't opening canal and meatus. I don't understand how they operate these tumors if they don't see the facial nerve in the temporal bone. And they have a regrowth 8.5%, but after 2 years of follow-up. But the reoperation for these patients, it's very complicated because there is a swelling, there is a brainstem compression. So it's much more different than our philosophy recurrence. It's only gamma knife and patient doesn't feel anything. But for this patient, I think it's very complicated. And the next surgery with swelling and the brainstem compression, it's very, very complicated. And this group from Switzerland, they published also this review, but there is incomplete data, diverse definitions of tumor control. So I think it's no value of this systematic review. So if we conclude, so now we have comparing two philosophies. Here, left side, low number of patients, very, very low follow-up. You can see if there is a remnant of the 6 cubic centimeters, so the patient have 31 tumor progression. So it's very high for the patients, and the volume reduction is very important. But if you see that of the radical philosophy, SANA, 2,000, more than 2,000 patients, and we see that after radical resection or knee total resection, there is a 0 regrowth, and only if there is subtotal resection, there is 6% of regrowth. So I think it's a big difference in these two philosophies. And my summary is that the vestibular Schwannoma, large vestibular Schwannoma, it's like climbing the mountains. If you do this surgery, I think our aim is go at the top, which means radical resection. If there is a higher stimulation, so we can leave some film, but we bring to the patients very nice prognosis with 0 regrowth. If there is a big adhesion of the facial nerve, so we can leave the some remnants, but we treat only 5% of regrowth. The philosophy to go only the base camp and not to try to do the radical resection, it's not good philosophy, because if we leave more than 6 cc, then we have 30% or 37% of the risk of the recurrence. And conclusion, so Of course, radical resection at any price is no longer acceptable because facial nerve function is most important. It's very important. It's very clear for us. But primary goal should be complete removal or near total resection if we do this surgery, because it brings definitive cure to patients. And planned partial resection followed by gamma knife is not supported because we have no long-term results. We see only 5 years, no more. And this surgery, I think, should be operated in competent specialist centers with the patient for this beautiful surgery, but with target of the radical or near total resection with very good results of the House Brackman. So this is our philosophy, and more details is in this editorial in ACTA 1 year ago. Thank you.
Thanks, Martin. Thank you very much. I had to switch. I somehow lost connection in where I am, so I took my fellow's computer. Nice work. We will, again, I forgot to say, please, to the audience, put in your questions in the Q&A box and we will address them at the end. But for our third and final talk, Mustafa, go ahead and share your screen and start your talk.
Hello, good afternoon. Martin Morkos, my big brother and mentor, congratulations on your presidency of AANS. And thank you for having me. I also like to thank the distinguished speaker, Ashok and Martin, and the organizing committee and discussants. So my role is to defend the aggressive microsurgery, but from my understanding, Martin also, I echo whatever he said. So I thought he's going to talk about, he's going to defend this hybrid approach, but Martin did very well. Thank you, Martin. So I'm going to skip this. Ashok and Martin all discuss these. So these are the main treatment options. Observation is always reasonable and best option in some certain selected cases. Microsurgery to me is the gold standard. If you can remove, you should remove. And stereotactic radiation is good option in certain cases again. And planned intended subtotal resection and radiation, I'm completely against it. I understand in certain cases you cannot remove, and then you can either observe or radiate. But if you go there with the intended subtotal resection, I think you are doing disservice to the patient. So my aims in the vestibular schwannoma surgery, maximal safe resection, aim of gross total resection, if not at least near total resection. And while you are doing this, preserving the facial nerve function and hearing preservation, hearing function, and you shouldn't cause any mortality. We shouldn't even discuss about it, and minimal postoperative morbidity, and that is the facial or palsy or hearing loss. Selection of approach all depends on the hearing and the location of the tumor in relation to internal acoustic canal and in the cerebellopontine angle. And this is two cases to show very similar cases to show you how that fundal cap is important in decision making. This is one case. There's a nice fundal cap, and the other one, there's no good fundal cap, you see, and one is good for middle fossa. The one, although is larger, there's more tumor in the CP angle. This is good for middle fossa. This is good for retrosigmoid because there's a fundal cap. So this is important, and you can achieve gross total resection in these cases and preserve the hearing in like I did in both cases. I'm going to skip all these advantage of my approach of choice is if hearing status is okay with this approach, translabyrinthine approach. But again, level of hearing, fundal cap, position of the sigmoid sinus, the size of the mastoid bone, contracted bone versus large mastoid bone, and the location of the sigmoid sinus, too anterior or too posterior, and the experience of your surgical team, and then look at the dominance of the sigmoid sinus, transverse sinus, or absence of the sinus on the surgical side. But the size, I don't pay attention to the size when selecting the approach. Translabyrinthine approach, briefly. So you identify the internal acoustic canal and facial nerve very early, and very wide dissection, exposure of the internal acoustic canal. And please remember, by doing the extensive internal acoustic canal drilling and dissection, you also devascularize the tumor feeders coming from the dura. Okay, there are two types of tumor feeders in the acoustic neuromas: extradural, dural feeders, and intradural coming from the AICA. So, in my opinion, Translab is associated with less CSF leaks, and some meta-analyses also concluded this, but I'm not 100% sure. I cannot substantiate with any data, and definitely almost no postoperative headaches. Disadvantage: you have difficulty in long tumors. The main difficulty, if tumor is long along the cerebellar surface and the brainstem, is hard to visualize medial part of the tumor in unfavorable petrous bone anatomy. And sometimes inferior exposure also limited. Again, the only contraindication, active chronic otitis media or mastoiditis, or very contracted small mastoid bone with the very anterior position of the sigmoid sinus. A couple of case examples: 22-year-old nursing home, a nursing school student, so comes with this, and we discussed, it's obvious, right? It's 23-year-old, young, so you need to do your best to get this tumor out. And it's sometimes I can predict the vascularity from the T2, and we know that this is going to be hypervascular tumor, but same time we should preserve the facial nerve function. The hearing is not the question, and do the most radical resection you can. And I selected to go ahead with the Translab approach, and thanks to our neurotology colleagues, they do very wide, very nice exposures and good results. The gross total resection with the good preservation of the facial nerve, fat packing, no complications after the surgery, and grade 2 early, and grade 1 facial function, and has been tumor-free 6 years now. So size wasn't an issue. Jugular bulb is sometimes an issue in this, but there is a way of overcoming the high jugular bulb. Only thing you cannot overcome with the Translab and high jugular bulb is if this is a diverticulum. Sometimes there's anomaly of the jugular bulb, is diverticulum, and it protrudes into the canal, that you cannot deflate it even if you drill the entire bone around it. Cystic tumors, 5.5 centimeter, very high, you see. So we look into this cystic tumors. I don't think there's the significant difference in facial nerve outcome, and our study resulting in that way found the same result. There's no really statistically significant difference between the cystic tumors and the solid tumors in terms of facial nerve outcome. Again, Translab approach, this patient had hydrocephaly, ventriculostomy was placed during the surgery, and the fat packing, gross total resection with the good facial outcome, has been tumor-free 10 years. Same thing, cystic tumors. This is not truly cystic tumors. We shouldn't mix cystic tumors with this arachnoid space entrapments. This is a solid tumor with this CSF entrapment. So TransLab provides a better exposure in my experience, less exposure of the cerebellum, almost purely epidural approach. You don't even need to see the cerebellum. The only disadvantage is seeing the most medial parts in some unfavorable anatomical variations. Retrosigmoid is a workhorse. I'm not against it, and I still do it in cases that I like to preserve the hearing, or in cases that I need a short exposure time. If patient is elderly and I just want to go there to decompress the 8-year-old with large acoustic, you want to just decompress and buy time, that's perfect approach. And for perfect approach for hearing preservation with the fundal cap. So a couple of examples for that. Again, the hearing loss, small tumor, and there's a nice fundal cap, good result, grade 2, grade 1 in 3 months, and gross total resection with the hearing preservation. Large tumor, I went there to preserve the hearing because she's young, but I wasn't able to preserve the hearing, but we had the good facial outcome with the good facial outcome, but no, we lost the hearing, unfortunately. And a couple of cases that retrosigmoid approach was used at the other centers for tumor debulking. And this is one of the case, 40-year-old female, subtotal resection at the center that acoustic neuroma was born. And I'm embarrassed to show this case, unfortunately, but so retrosigmoid approach, normal hearing, lost the hearing after surgery, and follow-up, tumor grows. They recommend stereotactic radiation for this, gamma knife, and now patient also has a trigeminal neuralgia. Look at that, like the case Ashok showed, the kinking of the trigeminal nerve at the cistern by the tumor, severe, and this is the perfect case for TransLab. You want to come virgin, so you don't want to go through that retrosigmoid and more ventral approach, presigmoid drilling, and then this is the thing. I'm cutting the superior vestibular nerve there and initial debulking, and I don't see cerebellum here. See, and always sharp dissection. You should do the acoustic neuroma surgery like you are doing insular glioma or AVM. Okay, sharp dissection around the nerve, near the nerve, and no traction or blunt dissection, and debulking and going back to the dissection. Okay, these are very sharp, flat dissectors, and with samurai scissors, creating a plane. And this is my suction hand. This is the hand, non-dominant hand, but this is the most important hand. And I learned this from Jacques Morcos. You can adjust the suction severity with your thumb, and it should be subconscious level, and you get used to it and you keep doing it. You see, I'm suctioning the facial nerve and no irritation potentials at all because I'm adjusting as I need it. Okay, so again, I'm showing I'm going to skip this. Dissection of the facial nerve was not the issue here, but the tumor was more adherent to the trigeminal nerve, and we got that part, and immediate relief after surgery. This is the trigeminal nerve, and I'm moving traction, contratraction on the trigeminal nerve. Trigeminal nerve is different, can tolerate the traction, but facial nerve, sixth nerve, others cannot. Okay, so we'll go through this and get the final piece of the tumor out. Facial nerve stimulates at 0.05, very good prognostic factor, and gross total resection, good facial outcome, and immediate relief. Like hours after surgery, she didn't have any facial pain anymore. Another case, 31-year-old, debulking, recommended radiosurgery. He wants to think about it, wait a couple of years. Tumor is now bigger, and we removed the TransLab. Again, retrosig initially, we came with the TransLab, even though slightly higher jugular bulb, good results. 55-year-old in Europe, retrosigmoid craniotomy, subtotal resection. We don't have the original pre-ops. They leave this tumor gamma knife, stereotactic radiation. 2 years later, tumor is bigger. Why did they do all these? Very unnecessary. Translap, virgin site, and become grade 3 post-op day 1, grade 1 in 2 months. Same 60-year-old with hearing loss and walking difficulty, subtotal resection, cyberknife, and tumor grows again. And young patient, why you subject patient to the 2 treatments and you still have the growth, okay? Post gamma knife, same thing, okay? I understand, some tumors you can control and some of them, tumor control means no growth, right? Maybe tumor naturally wouldn't grow if you leave it, you left it alone. So again, the same thing, gross total resection, grade 2 facial function long-term. Do I have failures? Yes, not complications though, okay? You cannot have major complications in this case, in these cases. So large tumor, very depressive, obese and diabetic patient. I went there for the same goal, gross total resection. But like Martin mentioned, tumor, you start stimulating the facial nerve higher and higher. It's time to stop. You know that for this patient with the severe depression, the facial nerve function will be very important. Could I have pushed it? Yes, but we left tiny tumor here and near total resection, and she had the good outcome. It was retrosigmoid though. Patient also had good hearing. In the retrosigmoid, I worry about the growth because with even though you drill the canal, you cannot get the extra dural feeders that much. So I'll watch these patients at least 15, 20 years. So, and this patient is the same large tumor and no hearing, translap, and I had to leave this tumor because he told me his facial function is important to him and I shouldn't push, and it starts stimulating higher signals, so it's time to stop near total resection. This is a very recent case, another failure of the approach, choosing the wrong approach, okay? 29-year-old, I went there, I thought I can get it, but this was my main concern, this long tumor along the cerebellar surface and the brainstem. I said, I will try the translap. We tried it, failure. What should I do? Should I radiate? No way. We'll come back. We do retrosigmoid because the difficulty was I wasn't able to see the medial part of the tumor. Okay, so bear with me. This is like operating in AVMs. Okay, these are arteries. You have to skeletonize them, and they give tiny feeders to the tumor. You just take the side feeders to the tumor, leave the arteries alone. Okay, and same with the nerves. Okay. And go around it, sharp dissection, only sharp dissection along the nerves, peeling, spreading, and blunt dissection. You can do other locations. Okay, so I'm getting around it, and I'm close to the arteries there. You see, and that's the area of the facial nerve. I'm coming close. And lower cranial nerves. And this is the canal now. I need to find the facial nerve, right? I go change my planes back and forth between canal and the brainstem, cerebellum side. And this is and I leave the cochlear nerve intact for a while, and then I cut it. Okay, in the canal side. I cut it at the brainstem to identify the dorsal root entrizole of the facial nerve. There's always an ICA loop between. These are lower cranial. This is actually sixth nerve. You see, sixth nerve had 2 branches here. But as it came out from the brainstem, there were 2 branches of the sixth nerve. That's also very rare variations. Okay, keep in your mind. And this is, and again, the facial nerve, how it's played, and sharp dissection around it. Arachnoid knife to create a plane between facial nerve and the tumor capsule. this is the only chance you have. This patient is 29-year-old. You have to give her a gross total or near total resection. That's best for her. You cannot just say, I cannot do it. Then why did you become neurosurgeon? Okay, traction, contratraction. This is all brainstem. I am beyond the facial nerve, ventral to the facial nerve there, and debulking, making the tumor smaller. And this is the facial nerve again. Okay. I found these samurai sharp dissectors. I use arachnoid knife, samurai dissectors or samurai scissors all the time. And now I am winning. I got the arachnoid plane on the other side of the nerve. That's it. And we'll stimulate the nerve. I think this case stimulated the 0.1, but she woke up perfectly fine. Gross total resection and grade 1 facial function. And this is a forgotten function, okay? Nobody mentions about the function of the nervous intermediates. That's very important to some patients, especially the tumors smaller than 2 centimeters. If they didn't lose and compensate for their taste function, their life becomes miserable. They cannot taste anything. And unfortunately, we don't mention, and please pay attention to the nervous intermediates. I'm going to show it to the anatomy for the young guys. So this is the nervous intermediates. And smaller tumors, smaller than 2 centimeters, you can preserve it. If the function is gone, larger tumors, don't worry about it. And patients won't notice that. If they notice it, and if you can preserve it, it's perfect. And tumors smaller than 2 centimeters, you look for it and you try to preserve it. So I don't want to take more time. I'll stop here. And this is again the perfect outcome. He didn't have a hearing, functional hearing, and good functional outcome. So again, these are all, I think, cliche, choose the right approach, but over time this comes, okay? And my preference doing the translap in cases that anatomy allows me to do it. And if I fail, I'll come back. I'm not going to give up. And anatomy is always best, and your best friend, and following the microsurgical principles set by our pioneers, like you are doing AVM aneurysms or acoustic or petroclival meningioma. And I like to use these adjuncts to identify the facial nerve. I learned this from Fukushima, and I use sodium nitroprusside to overcome the vasospasm. And so we look at this is a very rough data, but how am I doing, right? So tumors greater than 2.5 centimeter, our facial nerve preservation rate is higher than 90%. And tumors smaller than 2.5 centimeter, near 100%. And no mortality, no major morbidity, and CSF leak rate is around 2% with the abdominal fat grafts in the trans labs and the lumbar drains. And one point I want to stress, we think that facial nerve may affect patients' postoperative functional status or how they feel about their current functional status. So Mayo Clinic actually look at this. If you leave tumor behind, even they have good facial outcome, they don't feel that great. They feel more anxious. And if you ask these patients, they will tell you, every time I came for the checkups, I start getting very anxious. Is my tumor growing? Is my tumor growing? And the ones you did the gross total resection, they feel much more relaxed. So this is important factor, and we need to pay attention to these kind of factors too. So at the end, for the young guys, please go to the lab. All dissection, microneurosurgery, whatever you are doing, spinal surgery or peripheral nerve surgery or intracranial microsurgery, spend time in the lab. And that's the best thing you can do. You in Miami, you guys have wonderful lab, so use it. And this is our lab, and we welcome everybody. If I took too much time, I apologize. Thank you, and happy to have any questions if you guys ask me.
Thank you, Mustafa. Very nice, of course, as always. Beautiful surgical technique. You know, maybe while I'll ask Eva to show a case, but maybe I can Mike, my partner, who does also a large number of acoustics. Mike, do you want to ask the panelist anything or comment on anything while Eva is?
Sure. Yeah, no, that was great. Both talks, all three talks were just fantastic. I mean, really just highlighting the points that I think all residents and early faculty should really kind of take to heart. And we kind of follow the same track of being aggressive the first time around, especially when they're small here as well. The one question I wanted to have is just kind of some of the details that you both touched about with the resection and stimulation and your response to stimulation of the facial nerve as you're going through the course. You know, there's definitely some nuances to that. You know, we all start at 0.05, but I think Martin talked about it a little bit and stuff as well. What are your thresholds when you stimulate? Do you stimulate first at the root entry zone, and then you find it in the you know, distal end? And then when you start seeing that you're not stimulating as well, either with the frequency or you have to go up on the stimulation, what is your kind of your moves there? Do you go back to the root entry zone and you always compare it there? And when you go up by, I think Martin was talking about going up by 0.02 or 0.03, that was kind of the error or the concerning time where you felt like you need to kind of reassess this idea of leaving a small layer on it. I just wonder if we could just talk about those nuances.
Martin, are you? I don't see you on video. Oh yeah, you're there. Did you hear Mike's questions? Yeah.
Thank you. So very important, it's in stimulation from the brainstem, of course. Higher frequency, we have a neuroscience, very easy one, and we always start 0.05. And if you manipulate the nerve, Mustafa showed us beautiful, the sharp dissection. It's fantastic instrument. And of course you manipulate with the nerve. So if 0.5 it's not enough, so we go 0.2. It's okay, but if I need more, so I am very careful, and then I don't attack more the interface between the nerve and the tumor, and I try to leave the film, and we thin by Cusa or by scissors to make the film as thin as possible.
So whenever you get up to 0.07 is your kind of, that's when you start to kind of scale it back a little bit, is what you're saying.
Yeah, 0.3 it's too much. So then I plan to leave some film. Yeah, 0.2. It's maximum.
0.2. Okay, Mustafa, what are your thoughts on that?
I do the same. I mean, you'll start with the lowest possible, and you stimulate at the brain. First, always find the brainstem, and if it is stimulating nicely, pick a couple of points. And stimulation is affected by few things: CSF, blood. You have to be where you are stimulating, it should be dry. And if you are going high, first make sure your stimulator, your field is dry. And if it is not, if you are going high, stop doing anything. I just irrigate with the nitrite, put the nitrite soaked gel foams and wait a little bit and do dissect. If I have other tumor parts I need to work, I work on those parts without irritating the nerve. And you can also watch the irritation potentials, right? They're kind of fibrillation. And if I'm going higher and higher, 2.2, if I'm stimulating at 0.2, that's a very good warning sign. And I will stop there. But sometimes it goes suddenly, goes flat. You stimulate. If you are at the really advance in your dissection, and this is the last piece, and it was stimulating nicely, and now you are leaving like a tiny piece. The question I always face, and I don't know the right answer, should I get the last piece since I lost it? I lost the potentials, right? Or should I go leave some piece there? And
Mustafa, don't you think particularly in experienced hands like yours, it depends what you think the actual etiology of losing that signal. If
Correct.
It's blood supply as opposed to a bad traction. So I would treat it differently when I'm doing it,
Exactly. So, if you take the vascularity, that as the surgeon. And
exactly
that you should not do.
right.
And it's going to go out immediately. But if it is traction, you know that too, that fibrillation goes off, that irritation potentials, and wait until they stop. It stimulates, keep going. And but again, don't push your luck, especially the young patients. And you can wait a little bit. And
sometimes we wait
a patient wakes up perfectly fine, and you think you are confident. When you can go back and clean more, you get that sense too. There are some tumors, you say that there's no way I can remove this tumor without damaging the facial nerve, right? There's no point coming back, but you get that feeling. I go back. I didn't blink my eyes to go back second time. Patient wakes up fine. Facial nerve is good. Take the patient back. Do the complete resection.
Yeah, no, those are great comments. And the only thing I wanted to add was just, and you both showed it in your dissections, is maintaining that really nice plane is so key when you're talking about stimulating, because as soon as you lose that plane between the facial nerve and the capsule, it becomes very difficult to kind of rely on that stimulation. And so it's so key. But you guys both obviously have excellent technique, and that was demonstrated. So thank you again for your talks.
Thank you.
Thank you.
Thanks. Eva, do you want to show the case?
Yeah, so this is, you can see my screen, right?
Yes.
So,
Yes.
yeah, so this is similar to the case that Dr. Bushgaya was talking about so I'll tell you about the case. So it's a 64-year-old woman who actually initially had an incidentally discovered right acoustic neuroma in 2011 after she was indoor surfing and then had a fall. And so she had imaging done for the fall, and it showed this acoustic neuroma on the right side. And at that time, she actually had hypoacusis and tinnitus as well. And so she went to another hospital. They ended up doing Gamma Knife a year later in 2012. And then 2 years after, she actually developed 2 years after Gamma Knife, she actually developed this right-sided V2, V3 dull burning pain that lasted a few seconds and was triggered by stress. And so we don't have the initial MRI, but this was the MRI that she had in 2014, which was about 2 years after her Gamma Knife. And you can see here that there's not much of a fundal cap or anything here. And the acoustics pressing on the trigeminal nerve. And so you can see here, she was being followed at the outside hospital where she got her Gamma Knife with serial MRIs. And so they got an MRI in 2017, 2019, 2022. And so in 2017 was 5 years after her Gamma Knife. And so at the time, her pain was still about the same, dull burning. And so you can see here, the lesion has decreased in size a little bit. It's still compressing on the trigeminal nerve a little bit here. Then in 2019, she actually started having this new sharp stabbing pain that was different than before, in addition to this dull burning pain. And, the triggers now were when she would talk, when she would chew and brushing her teeth. And so at that time, she had actually been seen in our clinic. And so if you look on the MRI in 2019, it looks to be smaller than the one in 2017, but it's still pushing on the trigeminal nerve. And so, we offered her intervention. She actually didn't want any at that time because she, was worried about facial nerve function and hearing. And so we tried Tegretol, which helped with her pain. And so that helped until a few years later in 2022, she actually presented to us again with even worsening pain. And so now she was unable to talk or eat given the pain, and she had tried multiple different medications. It didn't help. And so if you see in 2022, the lesion's actually gotten a lot smaller now. And so and the tumor is compressing trigeminal nerve a little bit, but now there's like this possible vascular loop right here that's compressing the trigeminal nerve. And so I'll show you the coronal. And so here's the coronal. So you can see trigeminal nerve is here, SCA is compressing from above, and the tumor is compressing cranial nerve 5 from below. And so, we wanted to ask the panelists to see, in this patient that had this 64-year-old woman who had this right acoustic neuroma, had gamma knife 10 years ago, the lesion's actually decreasing in size, but she's developing, worsening trigeminal neuralgia, on imaging, you see that the tumor's compressing 5, and then there's also possible vessel loop that's compressing it as well. And, she's really worried about intervention because of facial nerve function. And, she doesn't want any more decreased hearing than she already has. And so, what management options would you do? And so here are the key images from each of the years.
Martin, what shall we do? The gamma knife seems to be working in decreasing the tumor size 10 years later, yet trigeminal neuralgia, how do we differentiate trigeminal neuropathy radiation induced versus a true mechanical, either tumor or arterial compression? What would you do?
I think it should be both the microvascular compression and the tumor also, if I see well. So I will discuss the patient if she agree. So I think it is good indication for surgery for retrosigmoid, in my opinion. And there is two reasons to decompress the nerve from the CA, and also we can remove the tumor. So we don't see many adhesions after gamma knife, so I expect more difficult situation, but it's possible. Mustafa prefers translap, if I understand, if it's after gamma knife, the patient. Is it true?
No, if patient has a good hearing, and I think I can preserve the hearing and I will do retrosig.
Yeah.
Patient has no hearing, no serviceable hearing, or hearing at the very, like a 50%, just borderline. I discussed the options between retrosigmoid and translap. On those cases, patient has the very borderline hearing, and also we look at the ABRs and bad ABRs. Chance of hearing preservation is almost impossible.
Yeah. So my opinion, I would discuss with the patient. If she agree, I would suggest the retrosig approach.
What would be, Martin, what is the goal of your surgery? You go in with the intention of doing what?
I think the main indication is neuralgia, trigeminal neuralgia, and medication, it's not sufficient, and there is compression by SCA, and there is compression by the tumor also.
So would it be your goal to do a gross total resection of the tumor, or you can decide when you're there? Or
I think the main problem is the trigeminal neuralgia now. I think because the tumor doesn't grow, so I think now it's not necessary to do radical resection, because the tumor it's decreasing in the volume, I think.
Right, it is.
Yeah.
It is.
So I would.
Oh, sorry. Go ahead.
I would concentrate on the compression of the trigeminal nerve and microvascular decompression.
Okay. Mustafa, same goal or what?
I'd like to ask more questions about the patient. So hearing is still okay?
Yeah, she still has hearing. So she's able to hear from a telephone and everything. We didn't get a formal audiogram, but.
And then how is her exam, trigeminal exam? Does she have any sign of, decreased sensation?
No numbness.
Corneal?
No, it was all normal, except for just decreased hearing on the right.
But just to tell the audience, this is a very good question that Mustafa poses, because probably could partially at least differentiate radiation injury from a classic trigeminal neuralgia, the presence or absence of trigeminal deficits.
So assumption is if she has a trigeminal neuropathy, right, from the radiation, you should have more signs than the just pain. And if patient is, I'm convinced that this is a truly trigeminal neuralgia secondary to the tumor compression, I will resect radically, not maybe with the aim of the gross total resection, and decompress the trigeminal nerve same time. I think by removing most of the tumor, you'll decompress this trigeminal nerve.
I'm sorry, 1 second. Ignacio, can you hear us? I noticed my colleague,
Yes.
Fred Telishi, the chair of ENT, my colleague neurotologist, is here with us. Do you think you can, what do you call it, promote him to panelist? Ignacio, Telishi.
Yes, yes. What's his last name?
Telishi, T-E-L-I-S-C-H-I. Unless he doesn't want to, we're going to find out very soon. We're going to promote him, and if he turns his video off, it means he cannot join us. But he's asking a question, Eva, where specifically does she localize the pain?
So just the V2, V3 distribution.
Okay.
In the dull burning pain is V2, V3 distribution, and the sharp pain that she started having is also the same distribution as well.
Okay. Mike, how would you handle this case? Mike Ivan.
Yeah, no, I agree with what's been said. I mean, I think that surgery would definitely be the best option to kind of give her the best chance for pain relief. The questions that have been posed are key because, if you look at that 2022 scan, you could see that the fifth nerve is actually doesn't appear to be as compressed. There's a vessel there, but it's less compressed than it definitely was in the past. So the question is, when you get in there and if you find the tumor has retracted off of it, and there's not really a vessel on it, what else do you do? Do you do a neurolysis, a little bit of neurolysis of that fifth nerve or not?
Right.
With the idea that it's some radiation effects. And I think that would be things I would discuss with the patient beforehand.
Fred, it's good to have you. Fred, for the audience who may not know him, is a chair of ENT here with us, my colleague of more than 25 years. Fred, interesting, huh? Shrinking tumor with gamma knife, yet trigeminal neuropathy. What were your thoughts, or what are your thoughts?
Well, yeah, I don't see. First of all, thanks for having us. We actually have our whole group here. We postponed our journal club so that we could all attend. So the whole group is
fantastic.
Yeah.
I was going to say so many bad things about neuro-otologists. Now you're forcing me to be nice.
Now
okay,
you can.
And then great to hear and see Dr. Telishi. I had an opportunity to scrub with him many cases. I learned a lot from him, more than Jacques Morcos.
Well, that's the last time I'm inviting you. Go ahead, Fred. Tell us your thoughts. Oh, are you muted, Fred? We can't hear you. Yeah, you're muted.
Yes, muted.
No, it's my headset that does that.
Okay.
Can you hear me now?
Yes.
Yeah, this headset does that. No, Mustafa, it's good to see you. And I'm glad that you have such a great relationship with your neurotologist who gives you those big, giant views via the translab approach.
Yes, thank you, sir.
Yeah, I mean, what other option is there for this patient? I mean, inject Botox or do some, crazy stuff. Seems like there's really only one option to do tumor resection for them, and hope that it removing the pressure and do some other manipulations is helpful for them.
Yeah. Eva, just for the sake of time, why don't you continue?
So we don't have the operative video, but what we did was exactly what all the panelists said. And so we went in, got about 75% the bulking of the tumor, just so we could decompress trigeminal nerve, which is right here. And so you can see it's pretty well decompressed. And then I'll show you the coronal as well. And then once we decompressed the trigeminal nerve, we started exploring the trigeminal nerve to see if there was a vessel loop that was compressing it. And so here you'll see here, there was this duplicated SCA that's going to come up right here that we put a piece of Teflon in between 5 and the vessel loop here. And then there's that Teflon here, and then there's another piece of Teflon. And so the patient actually did really well post-op. She was discharged on post-op day 1, and then she had some new transient right V1 numbness that resolved at follow-up. And then at follow-up, she was able to be weaned off all medications, and her trigeminal neuralgia completely resolved.
She was one of those patients who absolutely did not even want to hear of the possibility of a facial palsy or losing hearing, which is why we were conservative. But, you know, if Peter Janetta was alive today, he would love this case, because he always used to say, even if there is a tumor causing trigeminal neuralgia, it's not the tumor, it's an artery that the tumor is pushing on the nerve that's doing it. And this, well, indeed was the case. I don't know why it became more obvious when it shrank, maybe some form of traction or something, but we thought that's interesting.
Jacques, the reason I asked about the specific location of the pain, we all remember the Hitzelberger sign with the sensory branch of the facial nerve in the canal. And if this had been localized really to the ear, specifically ear pain, we have a procedure, a transmastoid procedure, to resect that little nerve, and frequently that helps in selected cases to remove the otalgia. But this was obviously a different situation.
Right. Very.
May I ask you the technique of the microvascular decompression? You do interposition of the Teflon, or you move the vessel from the nerve?
I do both. I probably do what Fukushima used to call the bridge technique. So I skeletonize the arachnoid, the artery completely in a way, and then I like usually a triangular or rectangular piece of Teflon, as a bridge, as opposed to stuffing it.
To create the nerve absolutely free. I think it's better than interposition.
Yeah, she was very happy. Pain completely gone. Yeah. Matt, are you ready with your case?
Yeah, let's get started. I'm going to share my screen now. Can everyone see? Okay, so this is a case of a 12-year-old girl who presented with 1 year of progressive right, worse than left side hearing loss and imbalance, also newly diagnosed with NF2 and found to have bilateral posterior schwannomas. On exam, she, in addition to bilateral papilledema, although she had normal vision, she had horizontal nystagmus. And on hearing test, she only had 4% word recognition score on the right side. And then outpatient, she was started on steroids and Diamox. And so here's the screenshots of the scan, and I'll show you the scroll through. So T1 with contrast, much larger tumor on the right side, and then T2 coronal and axial. And here's a CT of the temporal bone for those that are interested. And you can kind of see a hint of, possibility of high writing a jugular bulb on the coronal of the CT temporal bone. So question for the panelist speakers, what would you do for this patient?
Martin, what's your approach to those young patients with tough NF2 tumors?
How is the hearing, the sides?
On the right side, practically non-existent, and the left side is really bad too.
And left side is better for hearing.
It's better, but it's not really.
Yes, but within weeks, this case has been co-managed by another one of my neuro-otology colleagues, Christine Din. She noted like a rapid hearing loss. By the time we operated on her, she was almost essentially deaf. on both sides.
So I would start the right side, the large the schwannoma, and then of course we try to preserve the hearing as much as possible. So the left side, the second time the treatment, but maybe right side radical resection, of course, and the left side I would try to ask Gamma Knife how they see the chance the prolonged hearing, and we will discuss the left side about Gamma Knife or surgery, but later. If there is some hearing, I would try to preserve the hearing with a conservative approach, but if there is hearing also, we should decide very quickly on the left side if Gamma Knife or surgery too.
So Mustafa, before you tell us your surgical ideas, if the family told you, are there any non-surgical ways to handle these NF2 tumors? What can you tell them from what we're learning in the literature?
I think Ashok presented some new.
Right.
Hard to pronounce them. What are they called? I forgot. So you can, especially NF patients, you can try those first.
Yeah, I'm sorry he's not here with us. He loves this topic.
Bevacizumab, whatever they call it. There's so many of them, I cannot keep up with them. My question is, before we talk about
the VEGF inhibitors, is that?
Yes, I think so. He said it in his presentation, but why does he have a papilledema bilaterally? I didn't appreciate much optic nerve swelling in the T2, or maybe I missed because you were running.
I'm not sure, but
yeah, definite papilledema actually, which is why we kind of had to make a quick plan, and the neuro-ophthalmologist, Dr. Lamb, very, very clear cut. There is no hydrocephalus, correct, Matt? I don't remember.
No, not really, no.
And no venous hypertension, right? As far as we can see on this MRIs, you don't see any venous hypertension,
no,
not hypertension, but venous occlusion or, okay. And then you said, you showed the temple bone CT, it's a high riding jugular bulb. And so I think in this case, I think Dr. Telishi also can talk more about this, but to make any kind of hearing implant, I think is preserving the cochlear nerve will be important. So I think whatever you do at surgery, extent of resection, your aim, try to preserve the cochlear nerve for future hearing implant.
You mean for a cochlear implant?
Cochlear implant.
Not for an auditory brain implant.
No. Right. So in this case, my approach will be as very large canal, and I'm really concerned about the jugular bulb. And at the same time, I want to preserve the cochlear nerve for cochlear implant. I will do retrosigmoid with aim of gross total or near total resection.
Fred, before you give us your opinion, I'm reading one of the audience questions, Jose Carlos Casquera, who said, why not operate on the left ear first with a cochlear implant at the same time? Because she's going to lose the hearing on the right side anyway. So maybe you can educate our neurosurgical audience mostly, about the thinking that goes in with the hearing rehabilitation.
So, I think, I don't see an option of leaving the right side tumor, given the size of it in a child. Christine could give us her impression on how well the latest clinical trials for chemotherapy are working. But I think it would be pretty miraculous to see, a dramatic response in the tumor size on the right side. Certainly it's a possibility. And if the parents wanted to start with some chemo on a clinical trial, that would be something to consider. But short of that, I think we would all agree that you just have to remove the pressure on the brainstem on the right side. There's no way to preserve the cochlear nerve on that side. The speech discrimination is already gone. I think it was 4%. So that would be a good side to attempt auditory brainstem implant. Patient already has enough hearing loss on the left side to be a cochlear implant candidate. So it's not like a single-sided deafness or anything like that. So, in a young child, hopefully has some years to live. I don't know if there's spinal tumors or other things that would be impacting the lifespan of this individual, but a try of an auditory brainstem implant, I think on the right with as much completion of tumor removal would be good. And then obviously we would want to do that via the translab approach, despite the higher jugular bulb on that side. And then for the left side, you might even observe it and see if this tumor is a growing tumor. You can put a cochlear implant on the side without doing any resection of tumor and seeing how well the patient does. You can certainly do an attempt at tumor resection and cochlear implantation. If you want to give that a try as well, once the patient has recovered from the right side. So there's a few different options there. They could even go into a clinical trial for chemotherapy once you've removed, the large tumor mass on the right side. So lots of different options there, but a cochlear implant would be reasonable in some scenario on the left and an auditory brainstem implant on the right.
Great.
Left side hearing also is severely diminished, right?
Yes.
Yeah, that's why we're talking about potentially cochlear implant on that side with or without tumor removal.
Right. Okay. Matt, you want to carry on what we did?
Yeah, so
then my neurotology colleague and myself.
We performed a staged, actually combined translab and retrosigmoid approach for the resection. We did place a auditory brainstem implant and then close with fat graft. So as expected, there was the high writing jugular bulb with the large sigmoid sinus, and there may even be a hint of sigmoid diverticulum there. So because of the limited corridor, we expanded the approach during the second stage. We were able to resect 99% of the tumor, but unfortunately, a facial nerve at the end of the surgery did not stimulate at 0.2 milliamps at the brainstem side. And then we were able to verify that 18 of the 22 contacts of the auditory brainstem implant were good at the end of the surgery. And so here is on the left side, the CT scan after stage 1, and then on the right side, the CT scan after tumor resection and placement of the implant that you can see.
Matt, I don't know, many in the audience may not have an ABI program. Maybe you can show them on this CT a little bit, the wire and where they're sitting.
Yeah, of course. So the electrode, the paddle, so to speak, with the 22 contacts are placed through the foramen luschka, into the fourth ventricle to be able to contact the brainstem. And during the surgery, one can make adjustments as needed to maximize the number of good contacts. And there's this wire that comes out, and then there will ultimately be a receiver that can be implanted higher up on the scalp subcutaneously. And then the rest of this is fat, and the fat graft here also helps to keep the contacts in place as well. So here's the post-op T1 with and without contrast. And and then T2 over here. And you can see here anatomically the 7A complex was preserved, but unfortunately the facial nerve function post-op immediately was house bracket 5 on the right side. And she underwent eyelid weight placement on post-op day 6 and then was discharged home on post-op day 7. Here kind of, we're going to have more discussions about the post-operative course, but unfortunately she came back post-op day 13 with headache, fever, vomiting, lethargy, essentially septic. And we performed a lumbar puncture and the CSF was consistent with bacterial meningitis. So we got a CT with contrast, even though it didn't show a discrete abscess, but there was, the enhancement pattern and the fat stranding was potentially concerning for possible infection. And so, for the panelist, what would you do for this patient now?
So Martin, it was, I don't want to lengthen the conversation too much, but there seems to be evidence of perhaps some purulent material and that required re-exploration. Do you think we can leave the ABI implant in spite of the infection and just do a washout? Or you think we should remove all foreign material because of infection?
I have no experience with this situation, but why not try the antibiotics and we will see, and you can remove if not successful, but I don't know.
Yeah, Mustafa, what do you think?
What kind of what did cultures grow?
Do you remember the organism, Matt?
Yeah, so Klebsiella.
Klebsiella, yes.
So that makes a big difference too, in my opinion. I don't have experience with the brainstem implants, but how difficult to put it?
I mean, it's not
scarring if you need to come back if you remove it.
The results are less good, and it really was working very well. I mean, Christine tested her, and she's one of the good responders early. I mean, we only have result early, and we had, I think, 17 or 18 of the 21 electrodes were working. So it was a very good placement that we hated to lose.
Yeah.
So just again to shorten, essentially she was re-explored. I was out of town. Christine re-explored her with Carolina Benjamin and wash out. Go ahead, Matt.
Yeah, so we had a discussion with the parents too about what they would prefer and the risks and benefits of leaving it in versus taking it out, the hardware, and ultimately the mother really wanted to give the daughter her only really good chance of getting hearing. So the fat was taken out, and then the pus was washed out, and then a new fat graft was placed, and then she was put on antibiotics. Her blood cultures actually grew Candida, so she was also given antifungal as well. And here's kind of the post-op CT scan. Unfortunately, post-op day 2, after the washout, she began leaking CSF from the wound. I don't know if I should just go ahead.
No, it's okay. It's becoming, kind of generic things, typical thing, lumbar drain,
exactly.
Prolonged infectious disease consultation, 6 weeks of antibiotics. Bottom line, we got away without removing the ABI regarding infection. Which is kind of against the usual principles of removing of foreign, body in the middle of pus. But now I don't know that will necessarily be the end of the story, but that's at least how we seem to be getting away with it early on.
I think because it happened so quickly that Klebsiella is one of those bugs that has a high risk for biofilm forming on plastic, but that takes weeks to form. So I think because it was so quick and you guys got in there so quickly to repair it, hopefully that was not the case in this case.
Yeah.
So we have, it used to be, as Jacques mentioned, that the the standard just to remove any foreign material. So with cochlear implants in particular, we used to just yank them out if there was an infection. But I think many of us now have experience where you can leave it in, you can irrigate with betadine, antibacterial solutions. If you can bring vascularized tissue, I know you had to use a fat graft here, but if you can bring vascularized tissue in some way, occasionally even with a free flap, you're better off, because then you don't have the non-vascularized fat there. So Christina and I spoke about this case a few times, and I'm so glad that you all were able to save the brainstem implant since it was working so well. I think it's, in selected cases, we are able to preserve those devices even in the face of infection. You're muted.
Great.
John.
Yeah, I hear you. Thank you. Thanks for those remarks, Fred. Let's now address the audience questions.
Just one more thing I just want to point out in that
ahead.
case, because we do have that clinical trial going on. We talked about it a little bit. So brigatinib is the current kind of drug that has kind of some success in the trial. We just finished up one of our trials here. Christine ran it actually. It's a tyrosine kinase and FAC1 inhibitor. And so if those tumors were smaller and not having brainstem compression, and there was some idea of possibly preserving hearing, I think that would definitely, she would have been a really good candidate. I know that that was ruled out for this patient, but there is some promising developments coming through for these really challenging NF2 patients with bilateral tumors that are small.
Exactly. Thank you, Mike. Okay, let me tackle a few of the questions. Ketan Bulsara, great to see you, my friend, from Yukon. Ketan is asking, let's ask Martin. Martin, by the way, are you still awake, handling questions, or you're
Yes.
okay? Okay. I'll ask you this question from Ketan Bulsara. Seems a bit counterintuitive, but what biological characteristic makes cystic tumors more radiosensitive? That's what was mentioned earlier. Do you agree with that? Cystic tumors more radiosensitive, or you would have thought, like the myth has always been that microsurgery is better for cystic tumors. Yet certainly Gonziolka has mentioned the opposite. Any comments on radiosensitivity and cystic tumors?
I saw the article about this in the first presentation, right?
Yeah.
And yes, but I have no experience because we don't irradiate the cystic tumors.
Yeah. Mustafa, any comment?
I don't think that's right. I'm just gonna say simply, cystic tumors are also notorious for sudden expansions and sudden growth. And what promotes the cyst formation is probably microhemorrhages within the tumor. So I will be nervous radiating any cystic tumor larger than 2 centimeters.
Okay. Question by David Croce. I'll summarize his question. What is the collective experience of the surgeons here of operating post-gamma knife? Is it always difficult? Are there cases where it looks like gamma knife wasn't even done? What does a dissection plane look like? I'll answer first myself. I've had both types. I've had cases where I asked myself, did they even give gamma knife? This plane looks really good. And of course, we've had those very scarred planes that made the dissection very difficult. Martin, what do you think?
We have not many cases, fortunately, because in our country we try to do the radical resection, but still I did a couple of patients, but some was good. I was surprised that the plane was good and it was possible to do radical resection, but some was difficult, and the nerve is more atrophic. So yes, maybe the half of cases was very difficult and half was surprisingly good for me. Yeah.
I will
What do you
agree
think,
with,
Mustafa?
I will agree with your statement. I think it's almost 50-50. Some cases are very good, like never had. And one advantage of it, vascular parts of the tumor that receive the gamma knife, they are less vascular, as more pleasant to debug. But sometimes I think it's related to how they deliver and how close to the surrounding structures. It can be the plane might be lost completely if that borders receive the significant more radiation. I don't know the radiobiology of these things, but that's my experience.
Eduardo Orego, can the Coos grade be used as an indicator for the decision of using radiosurgery alone or combined with microsurgical intervention? Mustafa?
No.
I know you love radiosurgery, so you're going to find any excuse to do radiosurgery.
No. I mean, it's just depends on the patient. We cannot generalize these things. Like Roberto Hero said, right? If you try to create an algorithm based on the Coos grade or that grade is this grade, you can be harmful to that particular patient. So each patient is different. Medical comorbidities, age, hearing status, size of the tumor, other anatomical features we mentioned. I wouldn't just base something just strictly on one grade or tumor size.
And while I have you talking, the next question by Mohammed Al-Shar, what is the dose of nitroprusside? Do you know? Or
I don't know.
It's
the same dose. Actually, they asked me when I gave the bypass talks.
Yeah.
I learned from the cardiovascular surgeons.
Yeah.
I can provide it if they privately email me. I have the formula in somewhere, but I don't know if nurses prepare that.
Okay.
Mustafa, do you use that for hearing preservation too? Because, we've shown and others have shown that vasospasm of the internal auditory artery can cause hearing loss during the dissection. And we use papaverine for that, but I don't know if you use the same nitroprusside.
I was using papaverine, Dr. Tilishi, but then for a while they stopped the papaverine production. And at that time, I started asking the other disciplines, what do you guys use instead of papaverine? They said, oh, we have been using sodium nitroprusside so many years. And in bypass, when I use the papaverine, I noticed that white flecks on the vessels. And nitroprusside doesn't give you that, and it's same way efficient. And I use it. Yes, I use in any tumor surgery, any surgery. I'm very close, and I manipulate the brain vessels. I use sodium nitroprusside, including for hearing preservation, facial, or any other tumors.
Martin, a technical question from Monica Quiroga about using the CUSA. Do you use the CUSA for acoustics? What are your comments as you get closer to the facial nerve? What's your advice to the audience?
Yes, I use for debugging the CUSA. If you have a good percentage of the suction and of the energy, I think it's safe. You can regulate the power, and I think it's safe. My teachers, they did it with some mechanical debugging, but I think the CUSA is good. And even if we prepare it very clear to the nerve, I think if you have very low energy, I have good experience with this. Of course, we can use also micro scissors if you need some very and sharp dissection, if you need some very special and very tiny debugging. But CUSA, yes, I use the CUSA. I like it.
Okay. I don't know if my other neuro-otology colleague, Simon Angeli, is on, but Simon, if you're here, Dr. Jose Carlos Casquera from Spain says hi to you. Apparently, you're good friends. Let's see. Eva, when I lost the network, I lost the first few questions. In a second, I'm going to keep going, but I'll ask you to read in a few minutes the top 2 or 3. Let me see. Dr. Fabienne Romero, blunt dissection, sharp dissection. Okay, okay. Dr. Fabian Romero wants more technical description of when to use blunt dissection, when to use sharp dissection, subperineural, so forth. Can you, maybe Mustafa, can you rediscuss a little bit at what stage of the surgery you use blunt, at what stage you use sharp?
I mean, I think I told.
I know you said it, but maybe
no blunt dissection. I mean,
well, you did say, it's okay. We all use it a little bit. You did say it at one of your video. I'm using blunt here, and that's why I think some of the people got
blunt
confused.
dissection only away from the facial nerve, and blunt dissection. If you need to do blunt dissection, this is hard to develop these skills. Just be careful. You are using like Yaşargi's spreading motions, but very quick, small strokes, not wide strokes. And you can do that very gently and create the plane between nerve and the tumor. I'm talking about facial nerve. And same with the lower cranial nerves too, sixth nerve. But the fifth nerve is different. It's more tolerant to the traction. So always sharp or at least semi-sharp dissection around the facial nerve. And when you have these 3 centimeter, 4 centimeter tumors, that subperineural, that description is gone. I know some people talk about this, but I cannot tell perineurium or anything like that. I just see the nerve. So
that's right. You're right. When they're giant, that doesn't exist anymore.
Yeah, even some moderate sized tumors, you don't see anything. But arachnoid plane, they have an arachnoid plane, you preserve them. There's no arachnoid plane, you do your best.
By the way, that description, I can't remember the name of the first author. It's a Japanese colleague, but it's actually wrong. It should be subepineurial. It's
correct.
But anyway, everybody uses the term subperineural, but should be subepineurial.
Epineurial.
Yeah. Dr. Alim Bayramov asking Mustafa something a little unrelated, but what's the advantage of the elite approach in comparison to retrosigmoid approach in case of jugular foramen schwannoma?
Ooh. That's a good. So I think Alim should email me this question later time.
Okay.
It's unrelated to acoustic, it's long of a discussion.
Okay.
So,
Alim, if you heard him, email Mustafa. Thank you. Dr. Jose Nalino, there is a difference between the semi-sitting and lateral position. I guess he's probably asking it as a question. Is there a difference between semi-sitting? Yes, well, yeah, I'll answer my part. I don't use semi-sitting for acoustics. I just do the lateral position, to avoid all the semi-sitting issues. And I'm more comfortable, and I don't have any issue with self-retaining retraction. I don't use them in acoustics. Now, of course, there are people like Marcos Tatajiba and Ugur Ture who love the semi-sitting position, and they've mastered it. And of course, Majid Sami, who pioneered it. But I don't know, anybody else wants to comment?
I use spine position, just spine head turn for translap or retrosigmoid. If patient has a short neck and body habitus is not favorable for that, you can put lateral position. But if I try to do semi-sitting position, 2 things. One, I don't like any position other than spine position. I don't like prone. I don't like sitting because it's not good for my shoulder or my back. And these surgeries you don't do in 2 hours. You work long hours. So second thing is, if I try to do semi-sitting position, I do it in certain cases, but not acoustics. Then it takes 2 hours preparation because our anesthesiology team is not familiar, is not well prepared for these things. So, and spine works very well.
Martin, any comments on positioning?
We do the small vestibular schwannoma grade 1, 2. We do in the supine head lateral, and the large one, the grade 4, we do the semi-sitting position. We have good experience from Sami because we visited many times in Hanover, and so yeah, we see some advantages because there is CSF going down and you have more hands in this position because you don't need the suction. Yes, but yeah, we prefer the for large vestibular schwannoma sitting position.
Eva, those are all the questions I have because I lost network. I know at the beginning there were a few.
Yeah, so there's two other questions. So Dr. Alim Bayramov asked two other questions. So the first one was to Dr. Astagiri. It was
Why he's not here?
Yeah,
What's the
I
question?
think some of the other presenters maybe will answer. What is the best management of patients over 65 years old with bilateral acoustic schwannomas with trigeminal and facial nerve involvement in cases of neurofibromatosis type 2 with previous history of stroke?
Well, you're asking a very complicated and pretty impossible question to answer in a, without real specifics. I'm not sure any of us can give you a generic answer, Alim. Maybe when you email Mustafa, you can torture him with that question as well, and he can enjoy answering it.
I'll answer it, Jacques.
Go ahead.
Chemotherapy.
Go ahead.
Chemotherapy.
Chemotherapy. Okay.
Yeah, and then his other question was to Dr. Sames, which was which surgical approach is better for acoustic neuromas in case of compression on the vagal and hypoglossal nerves?
About what? About
acoustic neuromas. So what surgical approach do you think is better for acoustic neuromas that compress the vagal and hypoglossal nerve?
Does it change anything? I mean, you're going to take it out anyway.
Yeah, there's always compression, right? I mean, this is
yes. But it's easy answer because we do only retrosigmoid approach.
Right.
We don't use the translab, and middle fossa also we don't use. So we do retrosig.
You can do both. I mean, retrosig or translab is
yeah, we can do both, but we prefer this.
You can control all these nerves easily. What approach is not important, Alim. How you dissect them is important. Don't get stuck with these approaches.
Yeah, and for the audience, I mean, when my residents ask me, like, what is the hardest surgery that you kept learning? I always tell them acoustic neuroma is the operation where, like, the longest learning curve for me, well into my attending years. I kept learning and learning little difficult things, not the petroclival meningioma and bypasses, but acoustic neuromas. Those subtleties you really only learn with more cases that you do. It's been my experience.
Yeah,
still learning.
Yes.
Same.
Yes, same.
Same. The main reason makes it difficult, in my opinion, that the outcome parameters, even in small ones, either hearing preservation or just cosmetic outcome parameters. We are not talking about hemiparesis saving lives, right? Face and the hearing, sensory, and the most important motor function for outlook. So it's just all cosmetic outcome parameters.
Any comments from any of the panelists to anybody else before we close the session?
I think Mustafa made a nice comment related to the outcome of these patients. And, you really have to look at your own experience, your own center, your own outcomes, and be honest about them with yourself and with your patients. Because as Mustafa mentioned, patients these days won't tolerate severe complicated outcomes, unless it's a really huge tumor with some other preoperative complicated issues. It's not cosmetic surgery, but it's sort of approaches the philosophy of that, in that if you're going to do something, you really have to have a high chance of a good outcome, because doing nothing is an option, and doing some type of radiation is an option in many cases, not all cases. So, I think we all need to keep that in mind all the time. What's compelling us to do something really invasive for this patient, and are we confident that the outcome is going to be good? That was a nice panel. Thank you all for including me.
Of course. Well, it's just past 7 o'clock, so Thanks for our neurootology group for joining us and enriching the session. And thanks everybody. Martin, go to bed. And
thank you.
Mustafa, good to see you.
Thank
Bye.
you, thank you, Dr. Morcos. Thank you. Good to see you, Martin. Dr. Telishi.
See you soon, I hope.
See you.
Yes.